Question 14, which of the following is the most likely underlying mechanism? Quickly skimming the answer choices: defect in the umbilical ring, rotation of the midgut, incomplete recanalization, bowel wall. Okay, GI, easy. This is a GI question. A 9-month-old boy is brought to the ED for intermittent episodes of inconsolable crying, during which he draws his legs towards his chest. He has had 2 episodes of vomiting and 1 bloody stool. He received immunizations at his pediatrician's office 2 weeks ago, but appeared well during that visit. On exam, he appears lethargic between episodes and appears to be tender to palpation in the right abdomen. Okay, so tender to palpation, right abdomen. Localization is very important. Guarding and rebound tenderness could not be assessed. Yep, it's because he's 9 months old. Okay, let's see. 2 episodes of vomiting. Okay, vomiting and 1 bloody stool. So hemorrhagic stool is not good. So pay attention to that if they tell you that's regular diarrhea without hemorrhage or hemorrhagic diarrhea, hematochezia. Other than that, he was at his pediatrician's office just a week ago or 2 weeks ago, and he was fine. So this is acute, and he has had intermittent episodes, so he's on and off. So let's go through this. If you have a diagnosis in mind, that's perfect. If not, let's try and figure out what we can eliminate here. We have right abdomen. Is there anything in the answer choices that would not be unilateral? Defect in the umbilical ring, allowing herniation. Umbilical ring, like an umbilical hernia, which would be midline, right? Not right abdomen, so midline. So probably not that one, just right off the bat. Rotation of the midgut around the SMA. So that's midgut malrotation. Midgut malrotation is congenital. So that usually presents much, much sooner in life. I think it's something like 40 or 50% of cases present within the first week. So this is probably not it, just based off of his age. So age is really important, laterality is important, and the acuity is important. So we can get rid of this one because of the age. Incomplete recanalization of the bowel lumen during fetal life is atresia. So when the bowel lumen doesn't form, it doesn't canalize. In other words, it doesn't, it goes from something like this where there's no hole at all to this. This is what's supposed to happen. You're supposed to get a lumen. When that doesn't happen, atresia, right? You're just stuck with this, and then no food can pass. So that doesn't really make sense. They probably describe like stringy stool, if any stool is getting out at all. Not sure where bloody stool would come from that. And this would probably also present earlier in life. So again, I'm going for the age here, getting rid of that. Bowel wall invagination around a lead point. Okay. And then that is our intussusception, ectopic gastric mucosa with a true diverticulum. Okay. Ectopic gastric mucosa. What the heck does that mean? This is good to know. The gastric mucosa, especially ectopic gastric mucosa, is just referring to your little Meckel diverticulum. So a little Meckel diverticulum, right? Your rule of 2s, 2% prevalence, 2 inches within 2 years of life. So we got the age. The age is fine. These Meckel diverticula can have some gastric mucosa in them. It actually is functional, so it secretes acid, and that can cause inflammation locally and actually some hemorrhage. So that's possible. However, Meckel diverticula tend to be painless. So that's why that one doesn't make sense. And so we've got our answer right away based off of that knowledge. However, let's talk about it. So intussusception is invagination around a lead point. So we've got a cross section over here, and then this is our bowel. Okay, so if the bowel, right, normally looks like this, it's just a straight tube, but if it invaginates, it'll look like this top image. And that's where the bowel kind of shucks in on itself or over itself. Something happens while the bowel is trying to digest, doing peristalsis, moving food along. It might catch on something. That's what the lead point is. And then you get intussusception, where it catches on something, gets stuck, and then it kind of just collapses over itself. And then this is what it looks like on a cross section. You get this like double layer. On X-ray or ultrasound, you might see the target sign. So target sign on imaging is pathognomonic. Otherwise, this is what it looks like. In a lead point, something has to be there for the intestine to get stuck on itself. So most commonly, lead points in children, this happens in children most often because the lead points are typically your Peyer's patches. So if you had, so let's say we have green here. Normally we've got these like little Peyer's patches. They're really flat, right? Typically they're pretty flat. And Peyer's patches are just lymphoid tissue. But children have very reactive immune systems. So what can happen is that maybe one of these gets hyperplastic, and then you got a big speed bump. And it's just one more thing for the intestines to get stuck on. Now, maybe there's another one, right? 2. And so ultimately that leads to something like this. Maybe you've got it in here, maybe it's over here. I don't know, something like that. It gets stuck on itself and it invaginates. So how did this happen, right? Lymphoid hyperplasia, typically most common Peyer's patches. What could cause lymphoid hyperplasia in this patient's history? It would be the immunizations, oddly enough. Typically, you see this after infection, but I have seen questions that show you intussusception after immunizations. Either way, the Peyer's patches can hypertrophy or hyperplasia, and you get bloody stool, right? They didn't say the buzzword. That's your current jelly stool right there. So the correct answer is D.